where you can have it play, and it says Lumateperone. So at least according to them, that's what it says, but I don't know if that's accurate or not.
It sounds prettier that way.
Lumateperone. So that's how we're going to say it today. So this is just going to be a brief overview. By no means is this all inclusive, but just to kind of give you a taste, because this is a drug that is due out on the market this quarter. So starting right about this time of year. I saw pricing information, but I did not see that it was officially launched and released. So objectives, we're going to look at the pharmacology. This one's a little bit different than our other antipsychotic medications. We're going to look at pharmacokinetic parameters, and then we'll compare some of the efficacy and safety data, although it is relatively limited. I will just give you a heads up on that, but at least what's available right now. So Lumateperone, Caplyta, maybe, it didn't have the pronunciation of the brand. So these are oral capsules. It's available in 42 milligrams. And the indication currently is for the treatment of schizophrenia, although it is currently being evaluated for use in patients who have Alzheimer's disease and individuals that, agitation associated with dementia, including Alzheimer's disease. And it's being looked at for the treatment of bipolar depression. So they have clinical trials that are ongoing right now. This was just the first official indication that did get approval. It's recommended, so there's no titration required. It's 42 milligrams given once daily. It is recommended to be given with food, and we'll look at why that may be in just a couple. So one of the things that's really exciting about the Lumateperone is the fact that it is a little bit of a different agent. So it is primarily a serotonin 5-HT, well, a serotonin 5-HT, a 2A antagonist. So it is the most potent for the serotonin 2A receptor. And then it has different affinities. So it's a partial agonist at presynaptic D2 receptors, and it's an antagonist at postsynaptic D2 receptors, which is a little bit different. So this has more moderate binding affinity at the D2 receptors. So from a balance perspective, we get a lot more inhibition at the 2A and a lot less at the D2 receptor, despite having the medication all on board. It also inhibits serotonin transporter, so the serotonin reuptake pump. It does inhibit that to a moderate extent. And it has some modulation of glutamate receptors. So the first one that starts to look at not only serotonin and dopamine, but also introduces glutamate. So modulation of the NMDA receptors and it seems to be NMDA receptors that are downstream from some of the D1 receptors. So it might be able to attenuate some of the glutamatergic tone. So again, trying to look a little bit beyond just a dopaminergic view of patients who may have psychosis. It also has some inhibitory activity at dopamine D1 and D4 receptors, and even less inhibition, but some. So for completeness sake, I did want to include it at your alpha adrenergic receptors, both 1 and 2, which, while it's not a lot, it may have an impact on some of the side effects that we see. So not necessarily a pure Me Too drug, something that really is looking at a few different models. And the hope is that with some of these other activities, it can help with agitation. They're also thinking that it may potentially help with sleep architecture, but they haven't quite gotten to that point yet. But it is being proposed. So other features of the Lumateperone. So absorption, it is very poorly absorbed. Its absolute bioavailability is about 4%. So they do recommend that it's taken with a meal. According to the package insert, when it's administered with a high-fat meal, it can increase the area under the curve. So this looks deceptive. So when a patient eats, it takes longer for the drug's concentrations to peak. It doesn't peak quite as high but there's more drug overall that ends up getting absorbed. So in order to have a greater area under the curve, or AUC, they do want it administered with food, even if the time to get to the max concentration and the actual max concentration themselves are later and lower. So once a day with food, whatever their biggest meal is going to be. It is decently distributed throughout the body, and it is fairly protein bound, so over 97% protein binding. I was looking for displacement data, and there's not much yet as far as whether or not this will have drug interactions, so to be continued on that one. But there are definitely drug interactions related to the metabolism. So lumateperone is extensively metabolized by both cytochrome P450 as well as some of the other enzymes. There's more than 20 different metabolites, and at least a couple of them do look to have some activity. Despite the fact that it uses all of these enzymes, the 3A4 is one of the major enzymes for metabolism of the lumateperone, and the package insert information recommends complete avoidance with cytochrome P450 inducers or inhibitors. So this may play a role in combination therapy. So if you think of your oxcarbazepine, carbamazepine, especially as they're looking at indications with bipolar disorder, this really may be something we'll need to keep in mind, and to see are dose adjustments available later on, or is it just if they have any of these agents on board, then we can't use it. With the inducers, it would mean that there's lower concentrations of this. So that's why I'm talking potential dose adjustment if patients are on combination therapy. In inhibitors, this is the only dose currently available, so we wouldn't be able to drop it any lower to avoid potential side effects that may occur. So it'll be interesting to see how this unfolds, but that is a significant consideration if you are going to use this product. Half-life is 18 hours. Why does that make a difference? Because it's going to take about 5 days to get to steady state. So from a check-in point with individuals to see how they're tolerating it, if things are beginning to work, at about that 5-day point is when the amount of drug in is going to be about the amount of drug that's been gotten rid of. It's excreted both through the urine primarily as well as fecally. With the excretion, it is almost extensively metabolized. So less than 1% is actually the parent compound. So again, that metabolism plays a huge, huge role. So recognizing that it is something we will want to keep in mind, that may play a role in who would be the most appropriate for use of this product. So there were a couple short-term trials that were done. This was one of the larger ones. This is actually the link. So we did not coordinate that, but that worked out well. That was the link that Dr. Messamore had included in the email reminder for this meeting here. So this was a phase 3 trial, randomized, double-blind, placebo-controlled in adult patients. They were having an acute exacerbation of schizophrenia, so they had to have a schizophrenia diagnosis. The primary outcome that they were looking at was the mean change from baseline in the PANSS scores, and this was a 4-week trial. So patients that were enrolled could be randomized to either the lumateperone 42 milligrams, which is what got approved, the 28 milligrams, or placebo. So under development, they actually had looked at 3 different dosing strategies. The 42 milligrams is what we currently have. So the patients that were enrolled were on average about in their early 40s, so about 42 years old. More than 75% of them were male. There were 450 individuals who were enrolled. Their baseline PANSS scores was just under 90. So they were relatively ill. And their CGI score was about a 5, just under a 5. So these patients were enrolled and randomized. They had great continuity within the trial itself. So they had more than 80% of the patients who were able to complete the full 4-week trial. The vast majority of the patients that had dropped out withdrew consent or they reported lack of efficacy. And it was about the same between all three of the groups. So whether it was they didn't feel that it was helping, or they just opted to no longer participate. On average, most of the people dropped out by about 2 weeks. So what that suggests is that there wasn't a huge tolerability issue when they first started treatment, but then after a couple weeks, they either opted not to continue or didn't feel that this was being beneficial for them. So the results that they found, the mean change in the PAN scores, so they saw reductions. So the 3 columns are the lumateperone, the 42 milligram, the lower 28 milligram, and then the placebo. So for the 42 milligram dose, the mean change over that 28-week time frame was a 15.6 point reduction. So they started at 90, so they were down to about 75. That was statistically significant compared to the placebo group, both when they looked at the mean change as well as the least square mean change. When they looked at the clinical global improvement scale, they did mean change from baseline, and again, they did the least square mean change. And in this case, both doses were found to be significantly improved compared to placebo. So overall, they saw improvement, and there's a graph on the next page that shows this a little bit better, but they also had a number of responders. So they define responders as those that had a 30% or more improvement in their PAN scores over that 4 weeks. So they saw more than a third of the patients who were on the lumateperone group actually had a greater than 30% improvement in the first month. And there was only about a quarter of the patients in placebo that had that significant of an improvement. So for the patients that it worked for, they did see pretty significant improvement. Now, these are the graphs that were taken from the article. They're nice and colorful, and I think it helped with the depiction so that you see the top left is actually the least square mean change from baseline in the total PAN scores. The bottom 2 panels are the positive symptoms and the negative symptoms. And then the upper right-hand panel is the least square mean change in the CGI. And I'm using my hands outside of the camera, so you didn't even see that. Sorry about that. So as you'll see, there was a significant improvement for the higher dose group in the total PAN score, not for the lower dose. And they saw significant improvement in the positive symptoms. And while the negative symptoms did differentiate from placebo, it was not found to be statistically significant. So they did see improvement. The patients seemed to look better, and they tolerated the medications relatively well. Related to tolerability, just to close up that phase 3 trial. So there were over 50% of all of the patients reported adverse effects. 50% of placebo patients, 56% of the low dose lumateperone patients, and 65% of the 42 milligram patients reported adverse effects. The vast majority of them were the sedation, and that seems to be the one that repeatedly is most frequently identified as the most common adverse effect. There were a couple severe adverse effects. There were 2 patients that had to discontinue because of severe adverse effects in the lumateperone group. One had orthostatic hypotension. So this wasn't seen in many patients, but it did result in discontinuation for the 1 patient. And then another patient experienced a seizure. However, it was noted that this patient did have pre-existing risk factors and a history of a seizure disorder ahead of time. But those were the two main serious adverse effects. These are the adverse effects that are taken from the package insert that are seen most commonly. What you will notice is that most of the metabolic adverse effects are not listed. So they do carry a warning for all of the metabolic adverse effects. It's an antipsychotic, they carry the same warning. The differences that they've found in weight change. So for that phase 3 trial, they saw a 0.9 kilogram weight change in the lumateperone group. They saw a 0.7 kilogram weight change in the placebo group. So those were relatively consistent. The package insert includes pooled analysis from some of the short-term trials. So the one that I presented, as well as another 6-week trial. And they found that the lumateperone group did not differ from placebo in the number of patients that had weight changes, those that had glucose abnormalities, or those that had cholesterol abnormalities. So at least at this point, not saying that there aren't. So an open label trial that went for a full year did find that there were approximately 8% of patients that were on the lumateperone that went from normal glucose levels to high glucose levels at the 52-week mark, and the same with cholesterol, so about 8% of them. Although at this point, it's not clear exactly the impact that the medication itself plays as opposed to the disease state, but that would be one we're going to want to keep our eyes on. So there's not a significant immediate effect on some of those metabolic parameters. As far as the black box warnings, I did put an asterisk here. So this is a class warning that there is dementia-related psychosis. Patients that are treated with antipsychotic medications have an increased risk of death. But as I had mentioned, they are specifically looking at this medication for treatment of agitation in that population. So we may see that change over time, but since it's just listed as an antipsychotic, it does carry that warning. So just to wrap up, so we save plenty of time for discussion as well as cases. So new antipsychotic medication, a little bit of a different pharmacologic binding profile, does appear to be relatively well tolerated, and it is effective for the treatment of psychotic symptoms. But some considerations we are going to have to keep in mind, especially related to drug interactions. And with that, I will stop my share and turn it back over.